Let's start it.
Sir, start it. You can start.
Okay. Now we have around 40 students here. Okay. So, good evening, everybody, and welcome to the 5th class of this Regain Renal Classroom Session 2. As you know, that we have 3 parts in our discussion. In the part 1, we discuss one case, and in the examination style, as you are going to appear in the DM or the DNB examination. And in the second part, we will be doing some OSKI sessions, some topics which we don't commonly discuss or read, so that we get some ideas and some inspiration to read those parts. And in the part 3, Dr. Aniruddha Datta, he will be discussing some few important trials which is not being discussed here at the end, if time permits. So in the first session, we are privileged and we are very happy to have with us the greatest of the great teacher, Professor Binay Sakuja. He is not only mentor and teacher of ours, he is the teacher of so many nephrologists all over the country and abroad. He is a guru in the field of the nephrology academics. He will be taking exams today. Welcome you, sir, to our sessions. We are very
Thank you.
fortunate to have. And Dr. Arna Banerjee, who is a third-year resident in the Apollo Hospital, Kolkata, DNB. She will be presenting the case. And with me, with my colleague Aniruddha, Dr. Aniruddha Datta will be there for the discussion of the OSKI session. So if everything is ready, Aruna, you can take the permission from your teacher and you can start the discussion.
Good evening, Vinay sir, Pratik sir, Aniruddha sir, and everyone present here. Sir, with your permission, I would like to start the history.
Yes, please go ahead. Yes.
A 60-year-old gentleman was admitted with generalized weakness for 7 to 8 days, shortness of breath for 2 to 3 days, and coughing of blood for 1 day. The history was given by the patient and his wife, and both were reliable. The patient was relatively asymptomatic about a week back, since when he noticed generalized weakness and lethargy to perform his daily activities. He developed shortness of breath after 4 to 5 days, which was insidious in onset and gradually progressive. It was aggravated on mild exertion, but it would subside on resting. It was associated with swelling of ankles, which was more towards the end of the day compared to the morning. There was no associated frothing of urine, presence of blood. However, there was a slight decrease in urine output. There was also associated coughing up of blood. It was about quarter of a cup. It was bright red and frothy. There was no diurnal variation. There was no associated nausea, fever, any chest discomfort, or bleeding from any other orifice. This breathlessness was not associated with any yellowish discoloration of eyes or urine, passage of any black colored stool or black vomiters. There was no sudden awakening in the middle of the night or palpitations. There was also no history of any rash, any joint pain, convulsions, leg pain, back pain, any nasal discharges, decrease in vision, loss of appetite, noting of any lumps or bumps, or any weight loss. The patient was initially admitted in an outside institute where he was told that his serum creatinine was elevated and his hemoglobin was around 5 gram per deciliter, for which he was transfused 3 units of packed red cells, and he was transferred to our institute for further management. Though he was not on regular follow-up for his diabetes and hypertension, he mentioned that his serum creatinine was in the normal range about 6 months back. At this institute, he was intubated in the emergency department. He was given hemodialysis through the right femoral hemodialysis catheter, and it was alternated with another shorter dialysis-like procedure with blood products. He was extubated by the third session, and by about the fifth session, he was on minimum oxygen, supplemental oxygen support, and his coughing of blood had also stopped. He was also administered 2 injections. One was once a day over 3 days, and the other was a single dose, and he was told that he would need this injection again in 2 weeks. He was able to lie flat. Once he was able to lie flat, a renal biopsy was done. Subsequently, he was producing about 800 ml of urine, and his hemodialysis sessions were discontinued. In the background, he is a known diabetic for over 8 years, and he mentioned that it was controlled on oral anti-diabetics. Sir, Pratik sir, may I continue?
You talk to Professor Shakuja, and if you ask according to
I think sir has left.
There might be some technical snag. Just let us
Okay.
stay for forever. Yeah, I'll speak to him.
So you have finished your history now.
So I have the past history, just left. And
Okay, pass. So after you complete the history, you just summarize or ask your sir whether you should complete examination and then summarize, or you summarize after the history. Then
okay.
history will guide you.
Okay.
Okay. So this patient was admitted how many days back in your institute?
About 5-6 months back, sir.
5-6 months back. Okay.
There is a Wi-Fi issue, so he is joining in. Yes.
Yes, sir.
Yes, sorry,
Yes,
we lost contact.
Yes.
sir.
Only just so you can continue.
Yes,
Yes, sir.
you had told us about the dialysis via the femoral route and the sessions of possible plasma exchange, and you
Yes,
can
sir.
continue from there onwards.
Yes. Along with that, he was also given 2 injections. Sir. One was once a day over 3 days, and the other one was one dose. And then he was told that he would need that similar injection after 2 weeks. Once he was able to lie flat, a renal biopsy was done. Subsequently, he was producing about 800 ml of urine every day, and his hemodialysis sessions were discontinued. So background, he is a known diabetic for over 8 years, which he mentioned that it was controlled on oral anti-diabetic medication, and a known hypertensive for about 5 years, needing only one medicine. He did not give any history of any requirement, any visual disturbance or requirement of any injections to the eye, any tingling numbness over the sole of the feet, any delayed wound healing, or any frothy urine before this admission. There was no past history of any hospitalization, history of any contact with a tuberculosis patient, or history of tuberculosis. He did not give any history of recent intake of any antibiotics, any recent vaccination, any change of his current prescription, or any prolonged use of painkillers or alternative medication. He works at a bank. He consumes mixed Indian diet. He denied any history of regular smoking or consuming alcohol. And he also had a normal bowel, sleep, and appetite. Family history, he could not mention any history of diabetes or hypertension in his parents, and there was no history suggestive of chronic kidney disease in the family. Sir, may I summarize, or I'll do my examination findings and then summarize?
I think you can go ahead with the physical examination. Tell us your positive findings,
Positive findings.
and then we'll go further.
Right, sir. The patient was alert, conscious, cooperative, and maintaining a decubitus of his choice. There was pallor. There was bilateral symmetric pitting pedal edema up to the ankles. His blood pressure was 124/78 millimeters of mercury in both upper limbs. And in the respiratory system, there was bilateral fine inspiratory basal crepitations. Apart from that, sir, all systems were unremarkable.
Okay, right. So, on the basis of this, can you just briefly summarize the story that you've told us?
A 60-year-old known diabetic hypertensive gentleman presented with low hemoglobin, needing blood transfusion, breathlessness, and coughing of blood, and renal impairment. He was given hemodialysis and presumably 7 exchanges of plasma pheresis, along with 2 intravenous injections. A renal biopsy was done upon stabilization, and his urine output subsequently improved, and the coughing of blood stopped, and hemodialysis was discontinued. And this patient on examination had pallor and bilateral pitting pedal edema. He had normal blood pressure, and there were bilateral fine inspiratory basal crepitations.
Okay. Yeah. So the important thing in this that you should emphasize that although there is a background of diabetes and hypertension of 8 years duration, the diabetes, but the present illness is a short one of just about a week or so.
Yes, sir.
So that is important because that is from where you are going to proceed. So, on the basis of this data, what is your clinical impression?
Sir, I would keep the syndromic diagnosis as a pulmonary renal syndrome, sir. Given that, given his coughing of blood, and given his renal impairment requiring dialysis, which happened over a short period of time, although I do not know his baseline creatinine, but he mentioned that his renal parameters were normal at least 6 months prior to this. There was no history suggestive of any macrovascular or microvascular diabetic complications as per his history. And given his hospital course where he required dialysis and presumably therapeutic plasma exchange, I would keep the syndromic as pulmonary renal syndrome, sir.
Okay, pulmonary renal syndrome. So, what exactly is pulmonary renal syndrome? Can you elaborate a little more detail on that?
Sir, involvement of the respiratory failure and concomitant renal failure qualifies as a pulmonary renal syndrome. In that, we have, if we look into etiology, we have immunological and non-immunological causes. And
But just a minute, do you have to, is it necessary to have respiratory failure to call it pulmonary renal syndrome?
No, sir. Respiratory impairment. Respiratory involvement.
Yes. Is it necessary to have respiratory failure? That's what I'm asking.
No, sir. Respiratory involvement along with renal involvement, sir. Happening simultaneously, or sometimes
I hope we haven't lost contact again.
No. Corona, please respond.
Hello, sir.
Did you hear me or not? I was asking.
No, sir.
Okay. What I was asking, as part of pulmonary renal syndrome, is it necessary to have respiratory failure?
No, sir.
Yeah. So I don't think you should emphasize the respiratory failure. There can be respiratory manifestations of various kinds, right?
Okay, sir.
You had respiratory failure in this patient. That's why he was intubated. He was put on a ventilator. Yes, but it's not necessary to have those manifestations when you call it pulmonary renal syndrome. Even if this patient had just presented with cough, hemoptysis, shortness of breath, and did not require a ventilator, he could still be called a pulmonary renal syndrome, right? That's the point I'm
Yes.
making. So it's not essential to have respiratory failure. And even dialysis requiring renal failure is not necessary. There could be renal involvement, there could be renal dysfunction. That also could be enough to call it pulmonary renal syndrome, right? So, mm, does pulmonary renal syndrome, I mean, to you, what does it really imply? In other words, are there specific kinds of pulmonary and renal involvement that will qualify for this term?
Sir, if you're looking into the immunological causes, then there will be concomitant involvement of the endothelial involvement, sir, or a basement membrane involvement. So the which would lead to the simultaneous involvement of the lung and the kidney, sir.
Mm. I get what you're saying, but see, there was originally such a definition of pulmonary renal syndrome that was described long ago. But then the syndrome has now been extended so that any pulmonary involvement combined with any kind of renal involvement is also called a pulmonary renal syndrome. For instance, I'll give you an example. For instance, if you have a patient with a nephrotic syndrome and he develops deep vein thrombosis in the leg and has pulmonary embolism, that's also a pulmonary renal syndrome, right? So you don't need to restrict your definition of pulmonary renal syndrome to just this kind of situation that you just talked about. That was what it was defined as originally, but later it was extended. So, any kind of renal involvement, any kind of pulmonary involvement, both of them occurring together or soon after each other will qualify for a pulmonary renal syndrome. That's what I wanted to clarify. Okay, go ahead with your. You were talking about the differential diagnosis of pulmonary renal syndrome in this patient. Go ahead with that.
In this patient, um, given his hospital course, we were probably dealing with somebody with an immunological cause. He did not, as opposed to the non-immunological causes. So, given the age, and so we would keep Anca-associated vasculitis as one of our differentials, and also anti-GBM disease. The other immune complex mediated or immunological causes probably do not fit into this patient's picture. However, we should also keep the infective causes and drugs should be ruled out. But given his hospital course, we probably think about the ANCA-associated vasculitis or anti-GBM disease in this patient.
Okay, I would agree with that differential diagnosis. That's fine. But why can't this be just a patient with diabetic nephropathy who's developed a pneumonia and has developed anemia as part of CKD? What would be against that kind of possibility?
So, from the history, given his the progression of his renal impairment, it was a very short course, which goes against the natural progression of a diabetic nephropathy.
Okay,
There was no history of fever, which would
okay,
probably go against a consolidation or a infective foci in the lung.
right.
And the anemia in CKD, if reaching a level of 5, I mean, he had an anemia of about 5 and he was symptomatic. That is, he had lethargy and weakness, and there was demonstration of hemoptysis. So probably had it been anemia of CKD, it would not have, he would have tolerated it better. And there is evidence of bleeding. And given the hospital course that he received, presumably plasma exchange, it points
Yeah,
towards
yeah, you're right. The fact that the serum creatinine was normal 6 months ago, which you mentioned, also would go against a diabetic nephropathy. You won't expect the renal failure to progress so rapidly. And the amount of hemoptysis that you mentioned also was quite large. So that would be unusual. So, yes, those points are valid. And the treatment that this patient received, possibly methylprednisolone and rituximab and plasma exchange, all those uh, all those findings go against the possibility that I just raised. So that part is okay. So coming back to the anemia, now why do you think this patient was so severely anemic?
um, so there was evidence of bleeding,
Yes.
and I feel
So there was blood loss which was significant. So that could be one explanation. Okay. Any other reason?
um,
Could there be a lot of blood loss which is not visible?
visible. Yes, sir. Aside the hemoptysis, there could have been alveolar hemorrhage as well, uh, which might not overtly manifest. I mean, show
Yes.
up as overt bleed. So, along with the hemoptysis, there might have been alveolar hemorrhage, which would explain his breathlessness and the anemia.
Yeah, that's an important thing to remember, that it's not only the overt bleeding or the overt hemoptysis that you should take into account. The bleeding may be there without too much of obvious hemoptysis. So there may be a large amount of blood loss into the alveoli, and that can explain the severe anemia in this situation, right? Otherwise, you won't expect anemia to develop so rapidly with a short illness. So that's an important point to remember. Okay. So between ANCA-associated vasculitis and anti-GBM antibody disease, um, anything that can help you differentiate between the two?
From the history and the clinical picture, sir,
Yes.
although this patient, so for this patient, sir, it will probably history and clinical examination will be difficult to differentiate.
Right.
But had there been involvement of upper airway and had or evidence of any rash
Yes.
or joint involvement, that
Yes.
would go in favor of ANCA-associated vasculitis as opposed to anti-GBM disease. However, this patient, it would be difficult to clinically differentiate because he did not have.
Yeah, you're right. So if there are other systems involved, as you said, the skin, the joints, the upper respiratory tract, even the eyes can be involved in an ANCA associated vasculitis. So if you have any of those features, they would support ANCA vasculitis as compared to anti-GBM associated disease. But if you have just pulmonary and renal involvement, then it becomes very difficult to distinguish between the two because the two would appear very, very similar. Right?
Yes.
Uh, does the does the history of the treatment that this patient has received, does that help you in any way?
Um, this patient received if the plasma exchange, the presumed plasma exchange,
Yes.
and the presumed pulse methyl prednisone dose
Yes.
will be given to both patients, sir.
Both patients. Yes.
Both patients. However, for anti-GBM, there is, giving rituximab in the first go, as in the initial medication is not recommended, sir. So probably that will differentiate.
Yeah. So that's another point that you can use. So that goes in favor of an ANCA associated vasculitis. There are very rare reports of use of rituximab in anti-GBM disease, but it is not the standard therapy for that condition, right? So that's another thing which uh, favors the possibility of ANCA-associated vasculitis, right?
Sir.
Uh, so in this kind of patient, what would be the investigations that you would order?
Sir, given how the patient presented, after sending the initial baseline investigation of CBC, of renal function test, a coagulation profile, and the electrolytes, we would uh, we would send some special investigation, the serological markers of
Before going to serology,
uh,
anything more
um,
basic?
uh, uh,
What
complete
about the urine
hemograph.
examination?
Yes, sir, definitely. The urine examination should be done.
Yeah, don't
Uh,
forget
yes,
don't
yes, sir.
forget the
Yes,
very
sir.
basic things. Yeah.
Yes, sir.
So what would you be looking for in the urine?
In the urine, sir, we will look at hematuria. RBCs in urine, and
Yes,
then
yes.
sir.
Yes, go ahead. So
Yes.
you look for RBC in the urine.
RBCs.
Anything else?
Evidence of then to segregate this RBC as coming from to be of glomerular in origin, we should look for evidence of dysmorphic RBCs,
Dysmorphic RBC.
which then evidence of and of course leukocytes in the urine, RBC cast in urine,
What about
and
protein? Will there be some?
proteinuria,
Yeah,
evidence of
proteinuria.
yes.
Okay. Okay, go ahead with the. You were talking about serology. Go ahead with that.
In the serology, for in this clinical picture, we would send for um, anti. We'll send for P Anca and C Anca, sir, and anti-GBM
Okay.
antibody. And
Okay.
however, we should ideally send for anti-MPO and anti-PR3 antibodies. And then we should not wait for the results, but commence our therapy. And similarly, we should not, in this particular clinical picture, we should not wait for, because renal biopsy will come subsequently, but we should not withhold therapy and wait for renal biopsy, but we should commence therapy and subsequently go ahead upon stabilization with a renal biopsy. Other than
Okay.
that, sir,
Are any of these investigations available to you or not?
yes, sir, they are available.
You have been told the results of those investigations or not yet?
Yes, sir. I have the reports, sir.
You have the reports.
Yes.
Okay. Okay, we'll come to that. Any other investigations besides what you already mentioned?
Uh,
Won't you do a chest X-ray?
Radiological investigation, sir.
Yeah.
Radiological, we'll go ahead with chest X-ray, and if the chest X-ray and even an ultrasound of the
Ultrasound.
abdomen should be
Obviously,
done.
before a biopsy, you'll do an
Biopsy,
ultrasound.
ultrasound.
Yeah. So these are the most important investigations that you should be immediately doing. Now, you mentioned C ANCA and P ANCA. So, what is the current status of ANCA testing?
Sir, previously, initially, the P-ANCA and C-ANCA was being done as the initial investigation through indirect immunofluorescence. However, now the recommendation is to go for anti-MPO and anti-PR3 antibody by enzyme-linked immunosorbent assay. Instead of going for P-ANCA and C-ANCA, sir, as the screening test.
Yeah, so that's a very important change that has occurred. So, doing indirect immunofluorescence and reporting it as C ANCA or P ANCA is actually obsolete, right? So, you need to test by ELISA with highly sensitive antigen assays, and this should be reported as PR3 or MPO ANCA positivity, right? So the C ANCA and P ANCA should be forgotten about. It may be worthwhile to know them because of their historical importance, but when you ask for the investigation, some labs are still doing the old indirect immunofluorescence. So please be specific about what you want from the lab. So that is important, right?
Yes.
And okay, can you just tell us what were the urine findings in this patient?
Urine, sir, had albumin 1 plus. There was trace glucose. RBCs were 70 to 80, WBC 3 to 5. And they did not, there was no phase contrast microscope. So,
Okay, no problem. No problem. Okay. In what are the different types of ANCA-associated vasculitis?
Sir, we have granulomatous polyangiitis. We have microscopic polyangiitis, and we have EGPA, sir.
What is EGPA?
Eosinophilia. Eosinophilic granulomatous polyangiitis.
Yeah, a slight correction there. GPA stands for granulomatosis with polyangiitis,
Granulomatosis. Yes.
right? And EGPA is eosinophilic
Eosinophilic
granulomatosis with polyangiitis. So the eosinophilic one was earlier called what?
Chokes-Strauss.
Churg-Strauss. And the GPA was earlier called?
Wegener's
Wegener's granulomatosis. And do you have a fourth variety also?
So then we have immune complex
No.
associated.
ANCA-associated. I'm talking of ANCA-associated.
I don't know.
Is there a renal limited vasculitis?
Yes, sir. Yes.
Right. So there are 4 different varieties of ANCA-associated vasculitis. Is that fine?
Yes.
Okay. In GPA, what kind of ANCA antibody will you find in the majority?
Sir, PR3 in about 70 to 75% patients will be positive.
Positive. What percentage can be negative for ANCA?
Around, sir, 10%, 10-15%, sir, can be negative.
Did you get the question?
Sir, sir?
Sir has asked you in which percentage you will get a negative.
Yes, sir. My phone. Sir has left.
Okay. This patient ANCA was positive and negative?
Sir, positive.
Which ANCA was done and by which method?
Sir, PR3 was done, sir, but I do not have the titer values, sir.
How the reports are coming, how they express the results, in which unit you get this?
So in titer, so it will be 1:80 or 60.
So, Mr. Amar.
I'm sorry, we had lost contact again. We are back. Yes. Yeah. So what I was asking is, can the ANCA be negative in a small percentage of patients?
Yes, sir. Around 10%, it can be negative, sir.
Around 10%, right? Okay. And what about in MPA? Sorry for the interruption, there was a phone call. In MPA, what kind of ANCA do you get positive?
Sir, predominantly it is MPO positive, sir. About
MPO positivity.
60, around 60-70%.
And in EGPA, how often is ANCA positive?
So around 50% it is positive.
Sorry, again an interruption. In in uh, in EGPA, how often is ANCA positive, and which one is it?
Sir, it is about 50%, sir, and it
Mhm.
is MPO
It is
positive.
MPO again. Okay, right, right. So, leaving aside ANCA for the time being, uh, supposing you get an ANCA which is positive, say it is PR3 positive, um, and you have the clinical picture, you have the urine showing microscopic hematuria. So, is it still necessary to do a kidney biopsy?
So kidney biopsy should ideally be done uh, because not only we want to establish the diagnosis, but it also helps with prognostication and
Mhm.
uh, with regards to mainly the course of the and prognostication as well, sir. Uh,
Prognostication. Yeah, but also that there are many situations in which you can get a false positive ANCA. There are many
yes.
conditions other than Anca vasculitis where you can get a positive test, and so you can be misled. So it is mandatory to do a biopsy. Although, as you already said, you mustn't delay therapy in case your biopsy gets delayed for some reason, like it was in this patient because the patient was on a ventilator. So therapy should never be delayed, but a biopsy should always be done in this situation, even if you have an ANCA positive test. Uh, so, when you do a biopsy, what are the findings that you expect to see in ANCA associated vasculitis?
Uh, there will be presence of necrotizing crescentic glomerulonephritis uh, in light microscopy.
Right?
Uh, there can be additional um, medullary angiitis and in immunofluorescence because there will be no staining, but sometimes IgG and C3 may be found, may be positive. And
What do you call that pattern when you said you may find nothing on immunofluorescence?
sub immune.
Immune, right?
Immune.
Okay, right, right. Do you know of any classification of histopathology that is also used for prognostication?
So there is a burden classification
Yes,
and
good.
Wick's
Yes. So, what
classification.
is that?
So there are four categories. So if it is
Yes.
more than 50% sclerosed, then it is the sclerotic. If there are more than 50% normal glomeruli, then it is focal. If there is more than 50% crescents, then it is crescentic. And
Yes. Cellular
if
crescents.
sorry, cellular crescents.
Yes.
And if nothing, it doesn't match any of them, then it is a mixed class.
Okay.
So
So, which
prognostically,
one of these has the best prognosis?
so focal,
Focal. And which one is the worst?
so sclerotic.
Sclerotic, obviously. And mixed could also be pretty
Yes.
bad. So, focal and crescentic would be better than mixed and sclerotic, right? And focal would be the best prognosis. Okay. So yeah, that's important. That's the burden classification was which was described in 2010.
Okay.
And on histology, is it possible to distinguish anti-GBM disease from ANCA vasculitis?
The presence of necrotizing glomerulonephritis goes in favor of ANCA. Even medullary angiitis will not be present in anti-GBM, sir. Sir.
And what about this immunofluorescence? Differentiation between
Yes, sir.
anti-GBM.
Also, sir, in the crescents will all be cellular in case of anti-GBM, as opposed to this ANCA-associated vasculitis. And sir, in immunofluorescence, there will be linear anti-GBM staining.
Why this is linear? Where is the antigen? It is not an immune complex. Antigen is fixed and antibody gets deposited there.
Yes, sir.
Okay. And can you differentiate by the crescents, nature of the crescents between these two diseases, Anca vasculitis versus anti-GBM disease, the age and type and...
Yes, sir. So usually in anti-GBM, they are all of the same age and they're all cellular. As opposed to ANCA-associated vasculitis, I can get cellular or fibrocellular and in the same section.
Yes. The anti-GBM based antibody comes like a tsunami, destroys all this glomeruli, and they're of the same age, maybe cellular, sometimes maybe fibrocellular, sometimes after some time they will be fibrous, but the same age. But in ANCA vasculitis, with different ages. Okay. And this is also immunofluorescence involved. Is it possible that there will be both present? This is the anti-GBM disease as well as Anca vasculitis in the same biopsy?
Yes, sir. There is there are there is an entity of a double anti-GBM antibody positive and ANCA-associated vasculitis, sir. In the biopsy, we will get findings of both, sir.
Yes, in those cases, you can get an immunofluorescence positive with different stages of the crescents as well as some amount of necrosis will be there. Yes. It's a combined. Is it bad or a good disease? If you get a combined disease, then it's a bad, worse disease than individual compared to anti-GBM disease or ANCA-associated vasculitis. It is a combined disease.
Sir, it is bad.
Prognostically is exactly there. Prognostically very bad. Okay. So biopsy is important. Okay, in this group of the patients to diagnose it, to prognosticate it, and to differentiate with the other diseases. Okay. So to call it a crescentic glomerulonephritis, how many, which percentage of crescents do you require to call it a crescentic? Suppose 20 glomeruli is there, only one glomerulus containing the crescent. Will you call it a crescentic disease?
So 50%, more than 50%.
So it should be
cellular crescent.
Whatever may be, whatever glomeruli you were seeing, there should be at least 50% of the glomeruli that should contain the crescent. Okay. And, okay. Do you know any other diseases which can also present with other than this anti-GBM disease, ANCA-associated vasculitis, and other diseases that also can present as a crescentic glomerulonephritis?
Yes, sir. If there is IgA vasculitis, it can present as a crescentic disease. And there can be, crescentic transformation of IgA.
Sir is back.
And even, sir?
Yes.
Yeah, so I was just changing my position to see if I could reconnect. There's been a problem again.
Okay. So
Uh,
yes, we are in the possible days how to differentiate between anti-GBM disease and Anca
yes,
vasculitis.
yes. That was the question I asked.
Yes, sir.
Uh, Sir, the presence of
Yes, Dr.
ne
Banerjee.
yes, sir. The presence of necrotizing lesion and presence of granulomas will go in favor of ANCA-associated vasculitis, uh, which will not be present in
Yes,
anti-GBM.
I'm unable to see you now. I don't know.
Uh, so my video is. Uh, uh,
No. Yes.
Uh, am I audible now again?
yes, sir. Yes,
Yes.
sir.
Okay. Yes. So I'd asked you whether you can differentiate anti-GBM from ANCA vasculitis on the biopsy.
Yes, sir. Sir, presence of granulomas and necrotizing lesion goes in favor of ANCA vasculitis, uh,
Yes.
as opposed to we won't find that in anti-GBM. Also, the crescents will be of the same age and in anti-GBM, but we may find cellular or
Right.
fibrocellular crescents in ANCA-associated vasculitis. In immunofluorescence, again, we'll find a linear anti-GBM, linear staining in anti-GBM disease as
Yeah.
opposed to
Linear
pauci
staining for what?
for and IF, na antibody, sir, against the
IgG.
antigen. IgG.
IgG linear. Yeah. So you
Yes,
should
sir, IgG.
specify
IgG,
which
sir. Yes,
immunoglobulin you are talking about. Yeah, that's
IgG, sir.
important. Okay. Yeah. So, and the other important point that you made is that the crescents all appear to be of the same age and at the same stage in anti-GBM disease, whereas in ANCA vasculitis, they may be at different stages of development. Right. The presence of granulomas, well, if they are there, they can help you, but they are not always present in
In kidney, yes.
ANCA-associated vasculitis. Not in
Yes.
every biopsy that you will see granulomas. Okay. So, with if you have a biopsy showing ANCA-associated vasculitis in this patient, how would you proceed as far as treatment is concerned?
So this patient presented with elevated creatinine, diffuse alveolar hemorrhage, and presence of uh, this patient had a PR3 positive, which came later.
Okay.
We would start, sir, with after stable, I mean, we'll give hemodialysis, and uh, for our specific treatment, we will commence on pulse methylprednisone, sir. Along with
Mhm.
that, we'll have to give therapeutic plasma exchange and either rituximab or cyclophosphamide. He's 60, sir, and he's completed his family. So we can counsel him, and we can give, if he's unable to afford, then we can give cyclophosphamide in this patient, sir, with pulse
Okay.
methylpred.
Did you say he was PR3 positive?
Yes, sir, he was PR3 positive.
Okay. Uh, so if you have a patient who's PR3 positive, would you prefer which one of these two would you prefer between cyclophosphamide and rituximab?
Sir, given that we know PR3 has a higher chance of relapse, so we would ideally choose rituximab, sir.
Yeah, and do you know of any study which showed a difference in the response? You're right.
Uh, um, Relapse in the RAVE trial, sir. Uh,
Yes, you're right. In
in
the
the RAVE
RAVE
trial
study, there was a post hoc reanalysis
analysis.
done, and that showed better outcomes in the group given rituximab as compared to those given cyclophosphamide. This applies to PR3 only, not to MPO positive patients, right? So I would prefer rituximab in this patient because of PR3 positivity. Okay. Uh, mm, what is the current thinking about plasma exchange in Anca vasculitis?
Um, so the KDIGO recommendation now is if there is uh, renal impairment or requiring dialysis or a serum creatinine of more than 3.4 milligrams per deciliter, if there is diffuse alveolar hemorrhage with hypoxemia, or if there is an concomitant anti-GBM antibody positivity as well. So in these three situations, we can add adjunctive therapeutic plasma exchange can be given, should be given.
Right, right. You're right about that. But what were the major studies which investigated the role of plasma exchange?
So there first there was one study called Plex. I think it was somewhere in 1900s. But after that, the two major landmark studies were the MAPEX trial and the PEXIVAS trial, sir.
Good, yeah. MEPEX and Plexivas. Okay. So, what did Plexivas conclude?
PEXIVAS trial had two endpoints, sir. One was regarding the therapeutic plasma exchange to be used as an adjunctive measure for uh, better renal outcome and for mortality benefit. However, it did not show any improvement. I mean, it was not statistically significant. No, there was no improvement to the patients who received adjunctive therapeutic plasma exchange. Uh,
Yeah.
and
So,
the
so Plexivas was negative as far as the beneficial effect of plasma exchange was concerned. But you have told us already what are the current guidelines regarding plasma exchange in this situation. What other important conclusion did Plexivas bring out?
Pexivas also compared the non-inferiority of low-dose glucocorticoid versus high-dose glucocorticoid administration, and they had shown that the low-dose glucocorticoid was non-inferior, and because of the burden of the side effects of glucocorticoid, uh, uh, we can use low-dose glucocorticoid.
Good. Yeah, that was the other important conclusion. So that, and how much, what would be your low dose
Uh, so
after the pulse methylprednisolone? How much steroid would you give?
it was weight based, and
Yeah.
in average, if I take a 60 kg person, then it was 1 mg per kg per day. Then in 2 weeks, there was 50% reduction in the dose, and then every 2 weekly, there was 5 milligrams per day dose reduction
No,
up to
I
15.
think you don't need to go into those details. The standard dose which was being used earlier was 1 milligram per kilogram to start with after the three pulse doses. And the low dose regimen is zero point 0.5 milligram per kilogram. That's it. That much is good enough to know. And when would you stop the steroids?
Um, 36 months. Steroids would be continued.
Would you continue them as part of maintenance therapy also?
Yes, sir.
So how long would that go?
Um, if we are giving azathioprine, then we are continuing steroids. And if there is one extended azathioprine regimen as well, sir, where up to 4 years they have given azathioprine with tapered dose of steroids.
But if you're not giving azathioprine, then if you're
No.
giving rituximab,
Rituximab.
then what?
No, then we'll wait 14 weeks. After that, I'm not sure, sir.
6 months.
6 months.
Yeah, you generally would stop steroids totally by 6 months. You don't need to give them beyond that, right? So that is the current recommendation. If you were to use cyclophosphamide, how would you give it?
So either intravenous or the oral cyclophosphamide.
If you were giving it intravenous, how would you give it?
Intravenous, sir, 15 milligrams per kg, 2 weekly, and
Yes.
up to 3 months. So 6 doses, sir. And that will be.
Yes, you said 15 milligrams. Sorry, 150 milligrams.
So 1.5 per
Can
kg.
you just repeat every
So
2
50.
weeks, 3 doses?
6 doses.
How long does the induction therapy last?
So 3 to 6 months.
3 to 6 months, yeah. So can you just repeat what did you say about cyclophosphamide? I couldn't hear that.
Sir, 15 milligrams per kg,
Yes.
2 weekly,
How
for
many?
6 doses. 6 doses, sir.
6 doses.
6 doses. 6 into 2
That would mean that would be 12 weeks of therapy.
3 months.
Okay. Well, usually what you do is you give pulses every 2 weeks for 3 pulses, and then you increase the interval to 3 weeks
3 weeks.
for 6 more pulses. So that completes a total of 24 weeks. Right? So that is the usual schedule of cyclophosphamide. Okay. Would you also sometimes like to combine cyclophosphamide and rituximab?
So in severe disease with organ-threatening disease, organ-threatening events, there have been following the Rituximab trial, there have been a combination of IV cyclophosphamide with rituximab, sir, especially where there is renal involvement.
Yes.
So it can be given, sir.
Yeah. So if you have severe disease and you want a quicker response, so in selected instances, you can. And in that situation, what people do is use rituximab in the standard dose, but use cyclophosphamide in reduced doses, either orally or intravenously, but in reduced doses, because you're increasing the immunosuppression and therefore you're significantly increasing the risk of infections, right? So that is why that modification is done, but that can be done. And that they were combined, as you said, in the rituximab study as well, right? Uh, so if you have put a patient on steroids and rituximab, and the patient remains dialysis dependent, when would you consider stopping them?
Uh,
How long would you continue them?
Somebody was on dialysis. If there is no improvement in 3 to 6 months, sir, and the patient is dialysis dependent, then continuing immunosuppressants would not be recommended, sir.
Yeah, generally what is said that if the patient remains dialysis dependent for more than 3 to 4 months, you can withdraw therapy unless you are continuing it for extrarenal manifestations, right? So 3 to 4 months is the upper limit if the patient does not come off dialysis. Um, what kind of infection prophylaxis would you use in patients on rituximab?
Sir, hepatitis B reactivation. For that, I have to do a screening. Then pneumocystis jirovecii infection for
Mhm.
steroid dose. So I have to put the patient on prophylactic sulfamethoxazole trimethoprim.
Yes.
And even for steroids, or antifungals should be commenced. Patients should be, before initiation, should be screened for hepatitis B, hepatitis C, presence of any latent tuberculosis, and any active infection. And vaccinations should be administered. However, live vaccines should be avoided. And
Okay. Um, if you are continuing to use rituximab for maintenance therapy, what complication can develop which can lead to more infections?
so patient can develop hypogammaglobulinemia.
Yes, right. So you need to keep checking their gamma
Immunoglobulin.
globulin levels, and you might need to replace their levels if there is significant hypogammaglobulinemia, right?
Yes.
Okay. What kind of after the induction phase is over, what kind of maintenance therapy is now recommended?
Sir, for this patient, considering this patient, sir, then we would, if ideal, we would maintain on the rituximab.
Right.
We could follow one of the two maintenance protocols of rituximab, and
So how
the
much and how much would you give, and after how much time would you repeat?
so for following the Mainritz trials, sir, we will give 500 milligrams into 2 doses at the end of induction remission. Then 500 milligrams at 6 months, 12 months, and 18 months. Then we should ideally repeat CD19 levels after 3 to 6 months. And based on that, we can give biannual doses, sir.
Yeah.
This
So
goes
the
up.
current recommendation is 500 milligrams every 6 months. The CD19, some people believe in doing that, some do not. So the standard protocol is 500 milligrams every 6 months. And for how long will you maintain that?
Sir, 24 months.
24 months? 48 months?
Uh, 103. I am not sure, sir.
Yeah, probably I will go up to 48 months. Although people say anywhere between 2 to 4 years, the last word has not been said on that. But if you withdraw the maintenance therapy earlier, then there is a risk of relapses occurring. So that's why I would continue till around 48 months. Uh, if a patient doesn't recover and wants a transplant, a kidney transplant, uh, when would you accept him?
Sir, the patient has to be, the patient can go ahead with transplant, but the patient has to be in remission for at least 6 months. The after which he can go ahead with transplant.
What about ANCA positivity?
Sir, ANCA positivity will not hinder transplantation,
Mhm.
but uh, it determines a prognosis in the sense that if ANCA titers increase or if it becomes positive after negative, then it can indicate a relapse. So probably we should keep a watch on keep track of the prior ANCA levels as well.
Okay. Yeah. So you're right that ANCA positivity is not a contraindication if the patient is in clinical remission. The extrarenal manifestations are in clinical remission for at least 6 to 12 months. So some people would like to wait 12 months after remission and then go for a transplant. What is the recurrence rate after transplant?
Uh, 0.1 to 0.3%. So
That would be very low. I don't think that is correct. It's
around
around
5%.
no,
5
it's
to
around
10%.
9% or so. It's around 9%. And okay, if a patient has a recurrence post transplant, what change will you make in his immunosuppressive regimen? If a patient has a renal recurrence, what change would you make?
Sir, the steroid dose will be increased,
Okay.
and maybe we could give rituximab. We have to give rituximab could be given, sir.
Rituximab
Not
could you or anything else?
or
Could you
we
stop
putting
MMF and give
MMF and
cyclophosphamide?
switch. Yes, yes.
Switch
Switching
to
MMF to
cyclophosphamide.
cyclophosphamide.
Yeah, that would be a reasonable approach. Okay. Uh, can you tell us, is there good evidence that ANCA are really pathogenic?
Uh, I didn't.
Not sure.
I'm not sure.
But currently, the thinking is that they are pathogenic. You can read up more about that. Are you aware of any experimental models of Anca vasculitis?
Um, their MPO, uh, I mean, I know that uh, I mean, it was a rat experiment where I think
Mhm.
patients, the rats were infused with anti-MPO antibody, and they had all developed crescentic glomerulonephritis. I'm not sure, sir.
Not sure. Okay. You can read up about that. Does complement have any role to play in the kidney lesions?
Um, uh, The alternate complement pathway is upregulated, sir, in the pathogenesis of at the time of priming and activation of neutrophils, and
Right.
through the C5A, it gets in the amplification loop and leads to neutrophil recruitment and trafficking, sir. So it
Okay,
does
you're
play a
right.
role, sir.
So, therapeutically, has that been used?
Sir, C5A receptor antagonist avacopan has been uh, has been recommended as a steroid reducing agent in ANCA-associated vasculitis.
Yeah, so you can use avacopan as a steroid sparing agent. In
Yeah.
that case, you don't need to use steroids. You can substitute them with avacopan. But of course, that doesn't apply to us because that drug is not available in India. And in any case, even if it does
It'll be
become available, it's
expensive.
going to be very, very expensive, right? So that's another thing to remember. Have you heard of a new drug named mepolizumab?
Yes, sir.
I'm just trying
Uh,
to see how far you can go.
uh, so mepolizumab is IL-5. I think it is for EGPA, sir,
Yeah, it is for
because it is
EGPA,
EGPA.
and it's usually used for maintenance of remission of EGPA. And yes, you're right, it's an interleukin 5
5
inhibitor.
inhibitor.
Right. Okay. Now, before we finish, just a little more. So, can you have both anti-GBM antibodies and ANCA antibodies in the same patient?
Yes, sir. Yes, sir. There are a
So,
subset of patients, sir.
yeah. So, can you tell us more about that condition?
Um, um, Through the pathogenesis of ANCA-associated vasculitis, because of um, uh, the activated neutrophils and the whole cascade, the epitopes of anti-GBM antibody are exposed uh, in the basement membrane, glomerular basement membrane, because of which the anti-GBM antibodies also develop. So these patients uh, have a very their presentation is much like anti-GBM and anti-GBM disease, and they should be therefore managed in the induction as an anti-GBM disease, and their remission, because it is the circulating ANCA that is responsible for epitope exposure. So the maintenance should be continued as ANCA-associated vasculitis.
Okay. How often in say if you have 100 patients with ANCA positive disease, what percentage will have anti-GBM antibodies?
Uh, so 15 to 20%.
Maybe
One third.
5 to
No,
10%.
5% ANCA-associated vasculitis having anti-GBM positives.
And with the reverse?
Reverse will be, sir, around one third of the patients of
Yeah,
anti-GBM will
around
have ANCA.
30%. of anti-GBM positive patients will have ANCA. And what kind of ANCA is it?
It is MPO, sir.
MPO ANCA, yes. And as you already said, relapses are more frequent, whereas through anti-GBM disease is generally a single shot illness, but these patients have relapses, have a more aggressive course, and therefore they will require maintenance therapy as well.
Yes.
Uh, but how will you determine whether the kidney disease has been caused by the anti-GBM antibody or by the ANCA antibody or by both? How would you know which has contributed to what extent?
Uh, Clinically, we will not be able to differentiate. Even in renal biopsy, there will be staining.
So it's not possible to specify
It's
that.
not possible to specify.
Yeah, we currently don't have any way of finding out. Both could contribute, but it's not possible to determine the extent to which each of them is contributing to renal damage in that situation, right? So that's another exceptional situation. Yes. Have you heard of the Chapel Hill classification?
Yes, sir.
So what is that?
Sir, Chapel Hill classification is for, he has classified vasculitis into large vessel, small, medium vessel, small vessel, and mixed vessel based on affection of the smallest vessel. So we have small vessel vasculitis, which has ANCA and immune complex mediated, and we have medium vessel vasculitis. We have that is Kawasaki disease and
There are only two examples of.
yes, sir. Block.
Doesn't matter. Polyarthritis nodosa.
Polyarthritis nodosa. And
Okay, and what are the large vessel ones?
Giant cell arteritis and Takayasu arteritis.
Okay, and what are the small vessel ones?
Small vessel ones are ANCA-associated vasculitis, and then we have immune complex small vessel vasculitis, which includes anti-GBM,
Yes.
and IgA vasculitis,
Yes.
cryoglobulinic vasculitis, and
Yes.
that C1q related hypocomplementemic
urticarial vasculitis.
urticarial vasculitis.
Okay, right. So that is the Chapel Hill classification. Have you heard of imlifidase?
Imlifidase, yes, sir. Imlifidase
is it used in any of the conditions we've been discussing today?
Imlifidase is used in anti-GBM. It can be used in anti-GBM.
Yeah, anti-GBM disease. But what is imlifidase?
It's a monoclonal and no, it's not monoclonal. It cleaves the immunoglobulin, sir.
Yes, it cleaves immunoglobulin. So from where is it derived? From what do you get it? Or do you remember the earlier name? No, it was earlier called IDES, or immunoglobulin degrading enzyme obtained from Streptococcus. Okay, so that was the earlier name that was given to it, IDES. It's now called imlifidase, right? And it can be used in patients with anti-GBM disease. Any other condition where it can be used?
Transplant.
Pardon? Yes, transplant.
Renal transplant.
In which situation would you use it?
ABO incompatibility, high desensitive.
Yeah, you're on the right track.
So, in a highly sensitized patient.
Yes, for desensitization
Desensitization.
of a highly sensitized patient. So that is the other situation in which it is being now currently used. So I think we've covered a large portion of the subject, and it's almost 8 o'clock. So I think I'll now leave it to Dr. Prateek Das to sum up. In case he wants to ask you a few more questions, he's welcome to do so.
No, sir, this is an excellent and very elaborate discussion. We have also learned, every time I learn to you, I learn some, here to you, I learn something. Just my job is to summarize. So Dr. Aruna, you have presented a case of known diabetic hypertensive who presented with a short history of a pulmonary renal worsening. And so he asked you about what is your clinical impression and what exactly a pulmonary renal syndrome is, what is the old definitions. He corrected your mistake of a respiratory and renal failure. He told that any kind of respiratory or renal involvement can be called a pulmonary renal syndrome. And if it is there, then what does it imply? And these newer definitions, even a patient with renal failure with DVT and pulmonary embolism can be called a pulmonary renal syndrome. He asked you about the differential diagnosis. He asked you about why are you not thinking about is a diabetic nephropathy, proteinuria now developed pneumonia. You have rightly pointed out that is a short deterioration, significant hemoptysis, and there is a response to treatment of both the worsening. And he has asked about the severe anemia, why there is severe anemia. If there is even no blood loss, is there any reason for developing a severe anemia in such patients like alveolar hemorrhage? And he asked you about how to differentiate between anti-GBM disease and ANCA-associated vasculitis, the extrarenal involvement, pulmonary renal involvement, as well as response to rituximab, etc. You have already told. And does the treatment helps in cases of the GBM disease rituximab? He rightly pointed out that this is not very much recommended treatment for the anti-GBM disease. And then he has asked about what are the investigations will you do in the routine. She reminded you about the importance of the urine examination. It is a must. And to look after these RBCs and the dysmorphic RBCs, RBC cast. And he asked you about the serology, but don't forget for doing a chest X-ray and ultrasonography kidney in a patient who is having a pulmonary renal syndrome. Regarding ANCA testing, what is the current recommendation? So the historical importance was to prescribe P and C ANCA. Now you have to prescribe an ELISA testing for anti-PRC and anti-MPO antibody. And this he has asked you different types of ANCA-associated vasculitis, like EGPC, the terminology and the abbreviations that he has been corrected. And what is the fourth variety of this ANCA-associated vasculitis, which is renal-limited vasculitis. And then how much percentage of patients in a GPA, they have a positivity of the ANCA, and how much is the negative, and so also about MPS and EGPS, where you get in some cases ANCA positivity and in few cases also get ANCA negativity. So if there is a patient who ANCA PR3 positive, who is clinically having hematuria as well as pulmonary renal syndrome, then will you still do a biopsy or not? And he advised that his biopsy is a mandatory for this because so many causes of false positive ANCA in such cases. So when do you do a biopsy and what do you expect in such patients? And he asked you about the immunofluorescence pattern, specific terminology of post-immune disease. He has also asked you about this classification of the histopathology. This is the 4 categories, which one is the most severe or the worst prognosis and which one is the best. The possible differential diagnosis between anti-GBM disease versus ANCA-associated vasculitis in the biopsy regarding the age and stages of the crescent, as well as the granuloma, necrosis, etc. Now, in the treatment part, what is the major treatment available? Whom will you prefer for the cyclophosphamide in PR3 positive Anca vasculitis, and when rituximab? He has pointed out that in PR3 cases, rituximab scores over the cyclophosphamide. He has asked about this important trials and what the conclusions of the Plexivas trials regarding their take on plasmapheresis, and one additional finding regarding the dosage of steroid, what is the low dose of steroid, and how long you should continue in these cases, and when to stop, preferably at the 6 months of time. In the subsequently, he has also asked you about how to give cyclophosphamide in these cases, and in the induction phase, how long it should continue. Initial 3 doses at 2 weeks interval, and subsequent 6 doses at 3 weeks interval, that completes the 6 months induction course. Then how will take this is in the what you take on a combinations of rituximab and cyclophosphamide treatment in severe cases, and how to give them. He has rightly pointed out that the reduction of the cyclophosphamide dose with a normal dosing of rituximab gives lesser chance of infections. Steroids and rituximab in a dialysis dependent patient, how long will you continue the treatment? Such an intense immunosuppression, and it should be around 3 to 4 months time. After that, if patient doesn't improve, you can stop the therapy. And what about the prophylaxis? Particularly, this is against the bacteria, fungus, viruses. And this is a rituximab, how to give in a maintenance phase. Once the patient achieved remission after the induction phase, how to give rituximab. And then if you give a rituximab for a longer period, at a 6 months suppose interval, what kind of complications he can develop, he or she. And the maintenance treatment of rituximab, how to give that is a 500 milligram every 6 months, and it should be probably 2 to 4 years. Maybe his opinion, it is better to continue for 48 months. Then what is if the patient fails and wants for a transplant, what is the eligibility for transplant regarding the disease activity and ANCA positivity, and what is the chances of recurrence of the transplantation is around 9 to 10%. And with the pre-transplant, there's a post-transplant recurrence. So how will you adjust your immunosuppression dose, preferably replacing cyclophosphamide, replacing mycophenolate with cyclophosphamide? And is ANCA, whether ANCA is really pathogenic? This is a very important question nowadays. That is whether ANCA is pathogenic for the disease or not. Are you aware of any experimental model of ANCA vasculitis? Whether complement has got any role in the vasculitis, you have rightly pointed out. And he asked about the therapeutic implications and use of avacopan as a steroid sparing therapy in this treatment. And also the recent treatment, particularly in AGPA, that is the mepolizumab, what is the this interleukin 5 inhibitor. And what about this ANCA and both anti-GBM positivity, and they are how pathogenetically related? And if you get an ANCA positivity in anti-GBM disease, and which percentage and what type of ANCA it is, he has asked you about that also. And this is regarding the kidney disease. This is it is possible to differentiate between anti-GBM and ANCA, or the both. It is difficult to differentiate. He asked about something about Chapel Hill classification, large, medium, and small vessel vasculitis, and the recent development use of imlifidase and this antigen as this immunoglobulin degrading agents, their source and other uses. So with this extensive and elaborate discussion with huge experience and has given us the input. So it is a formality for us to serve what kind is the examination style, whether the examinee Arna has given satisfactory performance, and he or she she should pass in the exam. It's your opinion, sir.
Well, I think, but she can improve it further. I'm sure there is some scope for improvement. So just polish up her performance a little bit. But otherwise, she's done a reasonable job.
Yes, sir. So she should be slightly confident, more confident. She is only second year, so I think with 1 year time she should.
Yeah, I'm sure she will improve.
Okay.
In the remaining period of her course.
Thank you, sir, for this nice question. There will be moving on OSKI session. If you have time, you can stay, or just 15 minutes. It will continue.
Okay. I'll see how long I can stay.
Yes, sir. So Dr. Aniruddha, you please share your screen and give the OSKI questions too. This OSKI become popular during this COVID time.
Yes.
1 year
Absolutely.
DNB exam was totally on this OSKI based, and now the MBBS course has also been changed to many times. Even in anatomy dissection, there are OSKI stations only.
Hmm.
So for this, Arna, you have to read the question, read the problem, as well as give your answer as much as possible. And if you don't, then Aniruddha will help you in getting the answer. So Aniruddha
Yes, sir.
can start. So read it.
Sir, a 20-year-old male with on and off pedal edema, urine dipstick shows blood positive, protein, I don't know how much it is. I mean, it has glucoside.
Color is changed.
As much as protein is there and blood is there, sir.
Yes. So next.
20-year-old. One episode of macroscopic hematuria in the past. His blood pressure is 140/80 millimeters of mercury and with grade 1 ankle edema. Hemoglobin is 12.1. Total count is 5,600. Serum creatinine is 2 milligram per deciliter and urea is 65 milligram per deciliter. So renal.
Next one.
Yes, sir. Urine analysis. Identify the image. Sir, this is presence of dysmorphic RBCs. Sorry, Mani, this is a phase contrast microscopic depiction of RBCs, which shows a dysmorphic RBC, which signifies that it is glomerular in origin. And so with this background of glomerular hematuria, a young patient with protein and renal impairment, we would go for renal biopsy.
Yes.
24-hour protein is 2.1 gram. Ultrasound, normal, cortical CMD. Raised echogenicity with CMD alterations we cannot. So this is a subnephrotic range proteinuria with the presence of RBCs and loss of CMD.
Yes. So what will you do next?
Sir, a young patient, so should renal biopsy is not possible, to do a genetic study, sir.
So you do a renal biopsy inside.
Renal biopsy, yes, sir.
And this information do you need?
Yes. Serum albumin is 4.6.
Read.
C3, C4 is normal, ANA negative, ANCA anti-GBM negative. Albumin is normal.
Okay. So this is the biopsy.
In the biopsy, there is, I think this is silver methanamine staining, sir.
Yes. These black areas and IF studies also available, and the tubules are showing something.
Tubules have
The whole of the
Yeah,
glomerulus is
sir.
involved, or is segments are involved?
The whole of the glomerulus looks,
Is it FSG?
sir.
I think there's often droplets in the disease and
Okay, sir.
Significant. IF is negative.
IF is negative, sir.
Okay, that excludes one or two important disease. Yes, it is
IgA.
It's a negative. So the histological pattern is what? FSGS.
Droplet FSGS, sir.
Okay. So what did you ask for the next?
20-year-old FSGS.
In today's practice, light microscopy and immunofluorescence is enough for a patient of FSGS diagnosis, especially in classification of the FSGS.
Sir, genetic analysis should be done.
Will you ask anything in the biopsy?
Yes.
What is not done?
Electron microscopic
Yes.
pictures.
So what do you see here?
Sir, there is a food process effacement, sir. And they are all cool. There is irregular thickening of the basement membrane.
Yes.
There is irregular.
Okay. So membrane is irregular and diffuse effacement of these food processes in such a background. So what will be your diagnosis after this? So membrane is abnormal at the same time. So it is not a pure FSGS. So
should rule out Alport and basement membrane diseases, but then not basement membrane disorders, sir.
But it is irregularly. Somewhere it is thick, somewhere it is thin.
Yes.
Okay. So for that, your suspicion is of an Alport syndrome. Okay. Next, what will be the next step to confirm your diagnosis or additional investigation?
Would go for a targeted genetic sequencing, sir.
So you want to go for it? So will you not examine?
Yes, sir. I will do ocular and hearing, pure tone audiometry and slit lamp examination.
But are they very common in such cases? If you don't find any visual acuity abnormality or any audiometric abnormality, so you exclude the disease, or it is not that common, or it is not necessary mandatory nowadays? We need something more for diagnosing.
They may not be present, sir, but the disease is very big.
Yes. So will you take a family history or screen the family? We are giving the clue. You should give us the clue.
Yes, sir. Family history should be taken. And,
so if I give a family tree for this patient, can you read it? Next. So how to read a family tree like that, which is an index case and etc.
Circle is female and square is male, sir. I said ulta. The ones that are affected are in solid, and I think deceased is crossed out. So
So is there any
female.
sex bias in this? The males have severe disease and more significant disease. Females have either no disease or slightly less severe diseases. And according to
So it
this,
could be X-linked, sir.
yes, in X-linked, what kind of inheritance do you get? What do you call it?
X-linked dominant patterns.
X-linked dominant is a rare
X-linked recessive. I'm given this.
So it is in this picture, are you getting as a vertical, horizontal, and oblique kind of transmission in Mendelian variety?
There is a vertical transmission.
It's not a vertical transmission always. We're getting more of an oblique.
Oblique.
If you can see, the patient is affected on the maternal side, somebody else is affected. Okay. So in X-linked disease, you get an oblique kind of transmission. So you can get this, yes. So what do you infer from this pedigree tree, and what type of inheritance pattern, and what genetic testing will you prescribe? Just answer one line.
Inherit. What do we infer? It is an X-linked pattern of inheritance.
Because most males have a severe disease. Okay. Next. What is the type of inheritance pattern? Yes. It is also same. Yes. And the third question.
So genome sequencing.
So by this time you have a clinical picture. You have a more or less provisional diagnosis from the history. You have got a family history. So you have to prescribe the genetic testing. Okay. So next. Read it. This is the targeted genetic testing that was prescribed to such patient, this patient.
It is a collagen 4 called 4A5 hemizygous and X-linked. The variant significance is likely pathogenic.
So what is your diagnosis? Finally, you have the clinical picture, you have the family history, you have the genetic testing, light microscopy, electron microscopy, and genetic test. What is your diagnosis?
So this is a X-linked hemizygous Alport syndrome of involving collagen 4 alpha 5, so X-linked, with hemizygous inheritance.
Okay. What do you see there? What is this?
This is a slit lamp examination.
Yes.
There will be, I think this is anterior lenticonus, sir.
What is this called? Like putting oil.
Oil drop, anterior lenticonus.
So do you expect this kind of ophthalmic finding in this patient? Is it very common to be there at this age?
20 years. It can develop later, sir.
Finding. If you get, it will get in the 40s, not in a patient.
Later.
So our patient probably will not have this kind of finding. Okay. So next question.
What is
yes?
The sex of the patient that is being screened. Excellent. So this is continuation of the same.
Yes.
So male patients, sir.
So Aniruddha will give some information to you regarding this patient.
By biopsy and by features, we have mainly the X-linked autosomal recessive and autosomal dominant variants of Alport syndrome. What we were discussing that actually when we consider the other extrarenal manifestations like sensory neural deafness and the ocular findings, they are actually rare in the initial presentations. And even as we had a patient of 20 years of age, the eye findings mainly like this lenticonus come up somewhere whenever they have actually reached this end stage renal disease in the middle ages, as well as the sensory neural deafness that may be present in the majority of the patients, but by 15 years around 50% and by 25 years around 75% of the patients would be having. So it's not universal. And the carriers, that is the mainly the females, the intensity is much lesser. And these again, what we had highlighted that apart from the actually identifying, we cannot actually clinically identify an Alport syndrome only on the basis of these things. So we would try to diagnose the patients using genetic tests, because early diagnosis in the case of Alport syndrome gives you a benefit of actually treating the patients using standard of care therapy that may retard the disease progression. As well as if you are able to identify one index patient having an Alport syndrome, the benefit actually can be transmitted to the other patients in the family who would undergo screening, and if they are found to have the mutations as well as the early manifestations of the disease, they can be initiated on the treatment as well. So the ocular findings which we were highlighting, as we saw, the lenticonus is mainly seen in men, somewhere around 50% of the men, and it's very rare in female patients. So that's why the person whom we had screened would definitely be a male. And the importance of diagnosing these findings are that the findings like lenticonus, posterior polymorphous corneal dystrophy, as well as the retinal thinning, these may have an implication in predicting the type of mutation, because mainly these two are related with severe mutations or truncated mutations, which actually harbor or harbings that there will be early onset renal failure in the patients. And again, the presence of lenticonus in the female always highlights that the type of inheritance is an autosomal recessive one, rather than having a X-linked or an autosomal dominant. And moving on from the original classifications of Alport, now Alport is mainly classified on the basis of inheritance, that is X-linked, autosomal, digenic, or a suspected one when we don't have genetic data which are confirming the presence of Alport syndrome. So the patient here, the main thing is that what are the indications of testing, doing a genetic test in patients with Alport syndrome, that if you have corroborating clinical findings like sensory neural deafness and ocular findings, apart from persistent glomerular hematuria, the patient can be taken up for genetic testing, or if we have positive family history, or if we have pathological findings in kidney biopsy. All three of them were fulfilled in this case. The patient would be advised to undergo a targeted genome sequencing, as we are suspecting a collagen 4 disease. And also in patients in whom we have hematuria as well as variants of steroid resistant FSGS, they can also have underlying collagen 4 diseases. So the main advantages of having a genetic ideation of the mutation is you can prognosticate, you can monitor, you can predict the rate of recurrence in other pregnancies when you know the type of inheritance, and also you can identify relatives who are at risk. So when we have a workup of a patient who has persistent glomerular hematuria with normal serum complements, it's mainly divided on the basis of their pedigree and the clinical data. If it supports or suggestive of Alport syndrome, you can directly move on to a genetic testing. And if the pathological variant is identified, you can bypass doing a renal biopsy. If you don't get a positive finding through the genetic testing, or you don't have clinical or pedigree data which supports the presence of Alports, then a kidney biopsy followed by further genetic testing may be done. So
So that means we have to keep a low threshold for such patient of doing genetic testing, because all clinical parameters have a variable expression. Their percentage is also not fixed. It varies with the age and severity. So whenever suspecting a patient may have an Alport syndrome, in those cases, not very uncommon also, you have to give a low threshold for genetic testing. That is the message. That's why you have presented. So go on to the next cases. Next case, read it.
8-year-old female child with anasarca. On evaluation, hemoglobin is 9.5, total count 7,100. Total cholesterol 277, triglycerides 122, serum albumin is 1.7, creatinine is 0.79, urine routine examination, albumin 3+, RBC 7 to 8, pus cell is 2 to 3, and 24-hour urine protein is 13122 milligrams in 24 hours in 1900 ml of urine. So, 8-year-old child. Okay, so, sir, minimal change disease, nephrotic syndrome, child nephrotic syndrome.
Childhood onset nephrotic syndrome.
Childhood onset nephrotic syndrome.
Next.
Patient received 8 weeks of prednisone, 2 milligrams per kg. Subsequently, urine still has albumin 3+, serum albumin 2.2, creatinine 0.8, proteinuria is 7.4 grams, 8 weeks. Sir, after 8 weeks of therapy, if there is persistence of proteinuria, then the patient has steroid resistant nephrotic syndrome.
Steroid resistant nephrotic syndrome, at the same time some RBCs in the evening also.
Yes, sir.
So what is the next step for your evaluation and treatment?
For steroid resistant nephrotic syndrome, sir, we should go ahead with a renal biopsy.
So this is the renal biopsy. What do you find? Tell the stain and
focal. Sir, this is past stain, sir.
Yes.
Past stain is there is
by the membranes.
Membrane, yes. Glomerular basement membrane is okay. Sir, I think focal segment.
Yes, this focal. Yes, it's a segmental glomerular sclerosis. Focal you cannot tell because they only
focal I cannot say. Yes, sir. Segmental.
IF is negative.
Oh yes, IF is negative.
So probably is a probable FSGS is there.
Yes, sir.
Okay. So
the patient received CNI for 8 months.
Yes.
And still has serum albumin 3, creatinine 0.9, urine albumin 3+, 24-hour urine protein is 3.7 grams. Possible cause of proteinuria reduction.
Initially, she had 13 grams.
7 grams. Yes, sir. Sir, CNI is probably responsible for decreasing proteinuria by stabilizing the cytoskeleton of the podocyte.
Yes. Non-immunological. This is a mechanical event caused by this. Okay.
So this will be non-immunological.
So it will what type of response and what will you do next?
Partial response, sir. And next.
So non-response to steroid in 8 months, 8 weeks, and 8 months CNI is also a partial small response. So what we do next?
I missed electron microscopy.
So for every FSGS, you need an electron microscopy.
Electron microscopy, sir.
Yes. What do you see?
There is effacement of the food processor, and there is also areas of thinning and thick and thin, variable thickening of the glomerular basement membrane.
Not very irregular, it is almost uniform. It is thinner, rather looking slightly thinner.
Thinner.
Podocytes are all collapsed.
Podocytes are collapsed.
Lost their food processes. But
Okay, it is
content
thin.
yes, it is not very thick. Like the previous one, it was sometimes very thick and sometimes thin.
Okay.
Okay.
Thin.
So it's a childhood nephrotic syndrome, didn't respond to anything. Electron microscopy, we are seeing this. So what to do next? Investigation, this based on this EM finding. Because we have got FSGS, podocytopathy.
Podocytopathy.
What type of test?
So,
genetic test will be prescribed or don't prescribe?
So I will prescribe.
Yes.
I think I will prescribe genetic test.
So let's see the, and here also you read this genetic test report.
Call for A4. This is heterozygous autosomal recessive inheritance. It is pathogenic.
Yes.
And when so call for A4, and then additional findings, variants of uncertain significance detected. Okay, WT1 heterozygous for
So how this test is different from the previous genetic? In the last patient, you have seen the genetic testing, and here also you are seeing. So what is the difference basically?
So that was targeted. This is a whole genome sequencing, sir.
So why is this is so? Prescription is different. There was targeted. Here is a whole genome sequencing. Because that diagnosis of syndrome
was yes, sir. It was the pretest probability of that particular disease happening was higher, sir. As opposed
here you get a different syndrome. You have got a totally steroid resistant nephrotic syndrome, and this is not also the common teaching or common saying of these patients of Alport, but still you are getting the genetic abnormalities related to Alport. Okay, so there's a two spectrum, and also this is a collagen. Also, you can see this uncertain significance. What is the importance of this uncertain significance genetic abnormality?
Uncertain significance, sir, can sometimes interfere with the there is disadvantage of doing this whole exome sequencing, because I mean they may interfere with the diagnosis, sir, and also may because they may not be pathogenic, so they may prevent when the patient will be unnecessarily maybe subjected to extra testing, and maybe information that is not pertinent to the disease.
When this is uncertain significance becomes of great importance if you take the family and you test them and get the same kind of mutation in them also. Okay. Situation it becomes significant. Okay. So for these patients, so the two diseases of two spectrum, one where the suspicion was high about Alport, where the suspicion was not at all for the Alport syndrome. So does it come under the same spectrum Alport syndrome, and how to interpret the VUS mutation? So if you can tell, you can tell, otherwise Aniruddha will tell. Okay. Aniruddha, tell.
When we look at the spectrum of collagen 4 diseases, now actually it has been proposed that we look at the Alport syndrome or the collagen 4 diseases as collagen 4 related nephropathies. That the main classical severe Alport syndrome which are mainly which present with renal dysfunction, hematuria, and proteinuria in childhood. They are one group. The other groups, which are the moderate to mild group, like the females who are carrying the X-linked mutation. Previously, they were labeled as the carriers of Alport syndrome. Now, actually, it has been advised to rename them as Alport syndrome only, because around 12 to 15% of these female patients may eventually develop ESRD. And the other two variants, that is the autosomal dominant one and the digenic one, are also classified. And the other two spectrum of these disease, this collagen 4 diseases, are the Alport disease, Alport kidney disease with mainly proteinuria, or the nephrotic syndrome, which mainly presents as steroid resistant nephrotic syndrome. Mainly it was seen in adult patients having steroid resistant nephrotic syndrome. But however, even in pediatric population having primary steroid resistant nephrotic syndrome, a good number of population are they are shown to have mutation in the call4A3 and call4A4 mutations. And in these cases, mainly there is no basket weaving usually is not seen. Only thinning of the GBM membrane is seen, and the renal failure can be a little bit late. And the other part of the spectrum is presence of purely hematuric Alport kidney disease, which actually carries probably the best prognosis without having with having very minimal risk of kidney failure in the future. So again, as we were discussing regarding the recommendations of genetic testing, so depending on the type of etiology and multiple causes, if the patient's clinical spectrum or the family history highlights possibility of genetic involvement, like certain FSGS, family borne FSGS, or familial involvement of renal dysfunctions, or when we are evaluating for patients in ESKD of unknown etiology, or patients with atypical cystic diseases, or in patients in whom we are trying to evaluate as a kidney donor, there is a role of doing genetic testing. And mainly when we have a known spectrum, or when we know the possible pathological variant, the genetic testing to be advised is targeted next generation sequencing. When we don't know, and when we only are highlighting on the spectrum or the syndrome of the disease, then a large number of diseases or a large number of genetic panel has to be looked at. So a whole exome sequencing or a whole genome sequencing has to be advised. And when we are looking at diseases which are due to large chromosomal aberrations or large truncating mutations, which may be missed out when we are doing our next generation sequencing, in those type of diseases, a chromosomal microarray are usually advised, principally in cases of congenital kidney anomalies or syndromes like Dijot syndrome, where chromosomal microarray is advised. So these are the ways of doing the sequencing. It's either a Sanger sequencing, in which nucleotide by nucleotide the sequencing is done by base, the next generation sequencing, where we parallelly study all the panels and the chromosomal microarray. And the next generation sequencing can be of the whole genome, or of the whole exome, or it can be very targeted depending on the specific known variants of genetic mutations which are responsible for the disease we are working on. And for VUS, mainly the most important fact is to find out and to rule out the presence of VUS in the affected as well as unaffected family members. If we see the presence of the gene in the unaffected patient, family members, then the variant can be neglected. If it is not there, then further sequencing has to be done. And this genotypic phenotypic correlation is very important, especially in diseases like COL-A4, when the disease manifestation can be late. So in certain mutations, which initially are thought to be variants of uncertain significance, later on when the patient becomes clinical or starts to show clinical symptoms, they can be renamed as likely pathogenic variant also. So a regular follow-up is required whenever you are having a variant of uncertain significance.
Okay. So if you see the family tree of this patient, you can see the 3 generation and the 4th generation is shown, and your arrow is your target, your index case. This patient, this child is number 1. So what kind of Mendelian transmission? Is it initial one was an oblique one? This is a female patient having a which type of Mendelian transmission you are expecting? The one of the parents are affected, one of the grandparents are affected. So this is a vertical kind of transmission. If this is a vertical transmission, then oblique for X-linked recessive and vertical for
autosomal recessive.
Autosomal dominant. Recessive is a horizontal one.
Horizontal, yes.
Okay, so this patient may be suffering from a disease with an Alport gene, and this is an autosomal dominant variety. So drawing a family tree is important. You have to learn how to draw a family tree, and because you have to not to treat the patient, you have to take more patients as a donor in the family. You have to screen, you have to plan the family, plan the marriage, and so many things. And if you are not sure, you give a whole genome sequencing, but in most of the cases, these tests are very costly. So if you have high index of suspicion, you can also prescribe for the targeted genes for other family members. So next one. So that we have already discussed what we have to infer.
So how to treat.
So how to treat if you get such a patient? What treatment? One or two you already.
So anti-proteinuric treatment with RAS inhibitors or MRAs and even now SGLT2 inhibitors. Then I think some studies are there with atrasentan, so endothelin receptor blockers or combination of endothelin receptor blocker with angiotensin 2 receptors, parsentan. And
so again, the main treatment of Alport syndrome, as you correctly described, the first line therapies are ACE inhibitors or ARBs. Primarily, ACE can be combined with other aldosterone antagonists, and also certain trials have been going on, as you correctly said, on atrasentan, that was affinity, and certain microsilencing RNAs are also under trial, which is known as the HERA trial, and the NERV2 pathways inhibitors like bardoxolone is under trial with Cardinal. Mainly these three trials were evaluated for prevention of progression of Alport syndrome.
10 years later, the patient now has ESRD, initiated on maintenance hemodialysis, wants renal transplant. Multiple family members are willing to donate. How will you choose? This is autosomal dominant.
So the red circle represents the patients who are willing to donate, or the persons who are willing to donate.
So they are female, so we should get their urine routine. I don't know the age of the patients, but we should do a basic urine routine and urine protein estimation of the patients. If one is diabetic, so
for an autosomal disease, it hardly matters is a male or female. Eh?
Okay, sir. The one who is diabetic,
yes,
should be screened last, at least here. Then if there is a presence of RBCs or proteinuria, then actually they should also be, if they are willing to donate, they should also be screened for the targeted gene sequencing. If they are heterozygous, then they should not be accepted as donors for these patients.
So your mother is diabetic, so at least he is not considered to be a donor at the first moment. So aunt and one of the sibling, sister is there. So yes.
Both are ABO compatible, non-hypertensive, no urinary findings. How will you proceed to select the best possible donor? So I think we should do analysis of them also
Yes,
gentlemen.
yes. Next. So,
So aunt has heterozygous, so out. Sister is no pathogenic or likely pathogenic variant. No pathogenic or likely pathogenic variant. So sister
is a preferred donor because now
sister can be taken up, sir.
yes.
But
So,
age of this.
so aunt is even though he is asymptomatic, she is an heterozygous for this deletion of the gene. So she should not be accepted as donor. Sister is okay because she is not carrying any of this. Next. So this is the problem appeared with this HLA typing of the both the sister. They are siblings, but you can see the match and can comment. For a sibling, what
So
type
donor
of match? Yes. What match is there in HLA?
One. Asha, 3.
So as a transplant,
3, 9, 9 out of 12 mismatch, sir.
yes. So for a transplant physician, you have to prescribe in a form called Form 5 in TOHA Act. So how are you prescribing their siblings? So you cannot prescribe in a sibling. What kind of match you expect?
Haplomatch, sir.
Haplomatch. Is it possible
Parents,
that no match?
no.
There is 100% match.
The siblings.
They share one allele from father and one allele from mother. Okay, if they share the same thing, both the siblings are sharing the same allele from the parents, there will be 6/6 match. If they share 50%, then there will be 3/6 match. If they share the completely different alleles from the same parents, there will be 0/6 match. So it is difficult sometimes in cases of the siblings. So for that, what will you do next? So how do you establish your diagnosis in such cases? The relationship. Next.
I don't know, sir.
So here again, this STR analysis. Are you able to just explain?
Sir, I cannot interpret this.
So we will start with the question of selecting a donor within the family of an Alport syndrome having ESRD. So mainly the recipient's genetic sequencing is required to find out what was the actually a gene or mutation attributed and to find out the inheritance pattern. Next, the donor, once you have ruled out all the basic parameters of without having hypertension or other comorbidities or without any symptoms of any renal involvement, then as like in this case the sister and the aunt both did not have any kind of other extrarenal or renal manifestations of the disease, then as you correctly said, the genetic sequencing of the donor should be done. If the patient does have any kind of heterozygous mutations, or if the patient is positive for any kind of mutation, usually the recommendation would be not to donate, because even if you have a underlying heterozygous autosomal recessive one, or even if you are a X-linked female, your future prospect of having an renal failure is still around 10 to 15% in most of the cases. So to prevent that, you have to advise not to undergo a renal biopsy until unless there is no other donor available. If you have a donor available, if you don't have anyone available, then if the patient is an X-linked female and no other candidates are available, if usually they are more than 45 without having any kind of renal manifestation, and the kidney biopsy shows normal GBM thickening, then the possibility of having potential renal failure is a little less, and it's an acceptable risk. So the patient can undergo a renal, can become a donor. And for other homozygous variants, obviously you cannot donate. For autosomal recessive heterozygous variants, if again, like the similar for the X-linked female one, if you have a normal biopsy, then risk is acceptable. And for autosomal dominant ones, the advice is not to undergo a donation. If the patient is negative, you can always continue, like in this case for the sister. If the patient has a variant of uncertain significance, like if the sister backed out, then the aunt would have to be advised for the possibility of future risk of kidney failure. That part is not clearly known, whether that variant of uncertain significance would actually attribute to a increased risk for renal failure in the future. So that patient, if the patient is actually willing, or if the patient consents, then only you can take her up for a donation. So for this relationship establishment, mainly there are two type of evaluations which are done. That is the autosomal one, that is autosomal short tandem repeat sequencing, and the lineage markers for paternal and maternal. For paternal, mainly we use the Y chromosome STRs, and for maternal we use mitochondrial DNA or mitochondrial DNA related STRs. And for when you are trying to establish a linkage between father, mother, or a brother or siblings, mainly what we do is autosomal short tandem repeats. So mainly they are abundant through the genome. They are not usually coding sequences, but you just follow the pattern of them, how they are present in the index genes. So it came from the field of forensics, like how the FBI used to correlate the what I would say person-to-person relations were worked out. So this is a standard worldwide correlation which is done using these particular highlighted STRs. And using the matching in these numbers, the likelihood ratio for having a relationship is taken into account, and according to the frequency, you can establish the relation if they are siblings, full siblings, half siblings, or 3/4 of a sibling. You can calculate. So this slide actually shows the summary of what we discussed regarding Alport syndrome, that if you have the patient having when would you do the genetic testing, and what is the role of kidney biopsy? The therapy is mainly by ASARBs, and even if the patients are autosomal recessive or dominant, they need to be initiated on therapy. What are the monitoring parameters? That annual hearing evaluation should start from 5 to 6 years of age in cases of X-linked males, as well as autosomal recessive male and female both. And the eye evaluation should start by 15 years of age in both X-linked male and autosomal recessive male and female. So the final and last question for you.
Call for A4C, and I don't know the rest of it.
We are giving you this reports what we get when we advise for a genetic test, and what we get when we advise for a high resolution HLA test. Both these cases, how would you actually read or identify the nomenclatures for these particular reports? What are the nomenclatures for this?
I don't know.
Okay. So for the call for A1, like the gene, the italicized portion represents the name of the gene which is under study. Like here, it's for collagen type 4 alpha chain. The portion of the numerical shows the position of the nucleotide, and the letters G to A or whatever it is, it actually signifies what are the amino acids. Like here, what is the position of the nucleotide, that is like here from thymine to adenosine, and this final position shows what was the nature of the change in amino acid, that is like here in the 121st position arginine was changed in. So what the last sign or the cross or the equal sign represents, that if it is equal, it shows that it's a synonymous effect or a synonymous variant. So there is no actual difference in the protein which you are coding here. But once it represents with a cross, it actually highlights a stop codon. So there would be a possible trunking or a stop mutation would be there. And this HLA interpretation, as again, HLAs are the initial ones are the prefix, and up to 2 resolution, we know it's the specific HLA protein. The further resolutions are actually shown to highlight whether you are actually having a synonymous DNA substitution within the coding region, or whether you are having a difference in the non-coding region. And the last suffix of actually alphabet that shows what is the nature of the expression, whether it is not expressed, whether it is lowly expressed, like in our case, S shows that the protein which actually this HLA codes for is a secreted protein, or that would be secreted in the outside the sol as a soluble molecule.
So we have given this because you people, whoever is listening, will be practicing nephrology in a different way. You know, this Alport syndrome is much more than we're suspecting in the initial days. Getting one Alport syndrome may not be enough, because diagnosing more and more diseases, and you have to treat them for the medicines. You have to know the medicines at the same time. You're planning for transplantation, planning for other RRTs, chances of recurrences, screening the family, and giving advice to the family. These are also more important. So although it's a slightly difficult one, we have discussed in this OSKI, there is a how the clinical spectrum varies. There may not be a prototype presentation, there may not be a prototype investigations. There are different clinical findings are not enough, and genetic testing are important. How to prescribe them, how to prescribe accurately, and how to get the report and how to interpret them. That's why we have discussed this. As we are running short of time today, we are not discussing these clinical trials on the field of Anca vasculitis. Also, we have missed in the last membranous one. So we are planning for one class that will include both the important trials in the field of membranous disease and Anca vasculitis, and may not be one more, maybe a lupus in the subsequent classes. So with this, I thank you all for attending the classes. My sincere gratitude to Professor Binay Shakuja, Dr. Aniruddha, Dr. Arana, and also whoever is presented or listened to these classes. And at the same time, my sincere thanks to Mr. Shourav, and this is Amol and Ashish, everyone is present. So over to you, Mr. Shourav.
Thank you, sir. Thank you very much. I think that, it is a matter of immense pride to have Professor Sakuja amongst us. And that too, he has spent his invaluable time of around 2 hours dealing with this particular subject. And it is a great achievement. And I just would like to thank immensely to Dr. Pratik Das for structuring this particular course. And I can imagine the kind of in-depth discussion that has happened, and I'm pretty sure that it is going to benefit all the aspiring students. And in many places, the examination is going on, and this particular class will definitely help the student for their preparation. And thank you very much, Dr. Arhana, for braving the session and staying with us throughout the session. And real this one appreciation for Dr. Aniruddha for putting up these slides. So with that, I just would like to thank you all for staying throughout this session. We have around 135 plus live audience at various point of time, both in Zoom and the YouTube, and the entire session would be aired in the YouTube for your later viewing. So with that, I just would like to say Shubho Saraswati Pujo and happy Basant Panchami for tomorrow, and wishing you all a happy puja. Thank you very much. Good night and take care. Thank you, sir. Thank you very much.